All right, so we're going to get started. Firstly, everyone, thank you so much for coming. Welcome to the JOWMA's Women's Health Committee webinar on Obstetrics, Part 1, The Basics. My name is Nuchal Translucency. I'm a third-year medical student at Hackensack Meridian School of Medicine and the Secretary for the Women's Health Committee. JOWMA or the Jewish Orthodox Women's Medical Association, also known as JOWMA, is a nonprofit organization whose membership includes Jewish Orthodox female physicians and trainees. Our department, the Women's Health Committee, was created with the goal of increasing access to women's health education for the Orthodox community, thereby empowering women to be better equipped as self-advocates. We believe it's important to know about our bodies, know what's to be expected when women see their doctor, and know which questions to ask. If you haven't done so already, please take a minute or two to fill out this pre-webinar survey as you see on your screen. You can find the link in the survey in the chat. There will also be a post-webinar survey, which you will receive after the webinar. Please try to fill out both of these surveys that will help us conduct research on this education. Tonight, we'll be covering the topics of prenatal testing, genetics, and nutrition. We'd also like to remind you that this forum is not a substitute for getting individualized medical advice from your doctor. There will be a Q&A at the end of the event. Please keep your questions broad. All questions should be posted in the question box. When asking a question in the chat, please hit the Remain Anonymous button so that other attendees cannot see who poses this question. Your presence on this webinar is completely anonymous. Your video and voice are not enabled and attendees cannot be viewed. Our first speaker is Emily Goldberg from JScreen.
Hi, everyone. Thank you so much for having me. I'm just going to share my screen. Perfect. So what I'm going to do is just give a very brief overview about prenatal and preconception genetic testing. And then our other speakers are going to take it from there and go through it in a lot more depth. So I'm a genetic counselor at JScreen, so I just wanted to mention that disclosure. So for most women in pregnancy or planning a pregnancy, there's three main times where you're going to think about genetic testing. So carrier screening is probably the one most people are familiar with. So this is conditions like Tay-Sachs disease, cystic fibrosis, Fragile X syndrome. So these are conditions that you can screen for either before, ideally, or during a pregnancy. And it can tell you based on your genetics in conjunction with your partner's genetics, whether there's an increased risk to have a child with a genetic disorder. In general, these are done as blood or saliva tests. And patients can undergo this testing to figure out if there's anything specific that they would be at risk for. And then if a couple is found to be at risk, there's different options for genetic testing in pregnancy or even beforehand with in vitro fertilization. During pregnancy, women have the option for what's called aneuploidy screening, which our other speakers will go into depth about. But this is a way of testing for some of the most common chromosome abnormalities, things like Down syndrome during the pregnancy. They're not definitive tests, but they're an easy, low-risk way of letting somebody know if their pregnancy is at a high or low risk. And then a third option is prenatal diagnosis. So these are procedures, either a CVS or amniocentesis, where you can actually get genetic information directly from the fetus and have a lot of knowledge about the genetics of the ongoing pregnancy. For many people, they are referred to a genetic counselor in pregnancy. So I have on here just several different reasons, though it's not an exhaustive list, of why somebody might be referred to speak with a genetic counselor. So things like they've had some kind of genetic test in pregnancy and there's an abnormal finding, and we can explain what that finding is, what it means, and what additional information we can provide. Sometimes there's something in the family history or pregnancy history that warrants a further discussion or potentially more genetic testing. If somebody expresses interest in certain genetic testing, like a CVS or amniocentesis, and wants to learn about what those are, more details about what kind of information they can get, a genetic counselor can sit with them and really go in detail about some of those options. So just know that that's something that's available in the pregnancy. It doesn't have to be a scary reason for referral. A lot of times we see women who just want to have time to talk about all their different options and what's available to them in their pregnancies. So, you know, another thing I have over here is family history of cancer. And I think during and planning for a pregnancy is a unique time where we can really focus on women's health. And sometimes things come up during pregnancy, and while it may not be directly related to that particular fetus, it's good for their health and the future health of their family also. So just know that genetic counselors are a great resource that's out there, and definitely feel free to utilize them both before and during pregnancies for any questions that might come up. So thanks again, and I will pass it over to the next speaker.
All right, great. So our first speaker is Dr. Hindi Stoll. Hindi Stoll is currently the Director of Maternal Fetal Medicine and the Associate Residency Program Director for Obstetrics and Gynecology at Harbor UCLA Medical Center. She is also the chair of the hospital's Medical Legal Committee. She went to the University of Pennsylvania School of Medicine, completed her residency in Obstetrics and Gynecology at Johns Hopkins University, which was followed by a fellowship in maternal fetal medicine or high-risk pregnant obstetrics at the Keck School of Medicine at the University of Southern California. Hindi also earned a law degree at Southwestern Law School. Hindi cares for women with high-risk pregnancy and serves as a medical expert witness. Hindi is thankful to be an active part of the Los Angeles Jewish community and loves giving shiurim, playing basketball, and most of all, being a mom to 8 boys. She's a very proud wife of Rabbi Adir Passi, National Director of OU Synagogue Services and Associate Rabbi at Beth Jacob Congregation. Dr. Stoll.
Thank you so much. Thank you for that beautiful introduction. So yes, I'm coming to you from the West Coast. I don't know if our participants are which coast or perhaps the Midwest. So for us, it is still a little light in case you see some shadows on my face through the window. So apologies for that in advance. I was going to be discussing some aspects of prenatal nutrition. And in full disclosure, this is really a very brief discussion. This is by no means comprehensive. And I see, as the disclosures have been about the conference in general, this obviously is something broad and does not substitute for individualized medical attention. So first, I don't have a slide, but I'll state it, is that I do not have any disclosures relevant to this presentation. Sometimes I kind of wish I did, but I don't. So our learning objectives are to be able to understand the importance of prenatal vitamins and folic acid. We're going to learn about some other important vitamins and minerals. Again, as I said, this is not going to be comprehensive though. We're going to learn about weight gain recommendations, understand the famous fish consumption dilemma, and then just consider a few special considerations of a few special types of diets. So the first thing that I wanted to address, and honestly, if you remember nothing except for this one slide, to me, that's all I really, really want, is that women of, in my opinion, childbearing age, which is certainly kind of controversial, but in my opinion is between menarche and menopause. So basically at the onset of when periods start until periods go away, either naturally or because the uterus is removed. I really think that women should be on a prenatal vitamin. Again, I'm certainly not one who is promoting teenage pregnancies. I understand that menarche occurs at a very young age, so by no means am I promoting that. But I'm just stating the importance of prenatal vitamins at all points when a pregnancy could occur. And the reason is, as we'll get to in subsequent slides, is because the vitamins that are in prenatal vitamins are incredibly important at the very early stages of pregnancy, before a woman often knows that she's even pregnant. And so it'd be really important for any woman who is able to conceive So any woman basically who is sexually active, even if she's on birth control, we know there is some failure rate to birth control. So any woman who is sexually active, in my opinion, should be on a prenatal vitamin. The important thing is that the prenatal vitamin, I highlight it in a circle here, is that it can be any brand. It does not have to be a fancy brand. I put in here several generic versions, and I put in here branded versions, not because I'm promoting one or the other, but just to highlight that as long as the bottle says the word prenatal, it's fine. You're welcome to spend more and buy a brand name, but you can certainly buy your local over-the-counter. Again, I'm going to use West Coast pharmacies. I apologize if these are not in all of your areas, but CVS, Walgreens, just a regular pharmacy, Rite Aid. As I mentioned, it's important to have it before pregnancy. And you do specifically want the word prenatal. And the reason for that is because when the word prenatal is there, it is very particular in terms of the amounts of the vitamins that are included. So for example, some vitamins like vitamin A are going to be limited. We don't want too much of that. Anyone who is in the audience who either is currently on Retin-A related to acne treatment, or maybe someone who's been on in the past, it's not an uncommon medication for women to be on. Retin-A is teratogenic. Retin-A is high doses of vitamin A. And the prenatal, again, will show us that there's limited amounts. So just to kind of highlight the spectrum, something like Retin-A, you have to be on at least one, usually they require 2 forms of birth control. When you have the word prenatal, we have limited amounts of vitamin A. We have adequate amounts of folic acid, and we'll get to that in the next slide as well, but at least 400 micrograms. There's an increase in the amount of calcium because we need for the bone health of both the mother and the fetus. There's also an increase in iron. And I put an asterisk by the last one, iodine, because that one's actually a little bit more variable. It's creeping in, thankfully, into a lot of the prenatal vitamins that are out there on the market now, but it is not yet ubiquitous. And so it is very important to be aware and to kind of take that bottle and turn it around and look at what's in your prenatal vitamin. If it doesn't have iodine, no problem. Just make sure that you have adequate amounts of iodine in other places in your diet. And if you don't get it in other places, then you need supplementation for that. But it's important to know because not all of them do have it. So folic acid. This is probably one of the most well-known vitamins or elements related to a healthy pregnancy. And it's really known because, unfortunately, of its deficiency. So a deficiency in folic acid can relate to very severe fetal sequela, something called spina bifida or encephalocele, all within the larger context of a neural tube defect. And as I mentioned, folic acid has to be sufficient before pregnancy is achieved because the neural tube is formed at about 4 to 6 weeks of gestational age. And it's a little funny for those who have been pregnant or kind of remember how we calculate a pregnancy, right? We actually calculate a pregnancy from your last menstrual period, but you didn't actually get pregnant until roughly 2 weeks later. So we're talking about neural tube being formed only a couple of weeks to a month after you've actually gotten pregnant, certainly before most women show up to their doctor, right? They may have just started to miss their period, or especially if they're not fully regular, they kind of haven't even totally noticed it. So the neural tube is forming during that critical period of time when most women don't even know they're pregnant. That's why, like I said, if you take nothing else away from anything that I personally say, I'm sure my colleagues have lots to offer you. But the one thing that I'd recommend is to be on a prenatal vitamin from the moment sexual activity is initiated until basically either natural menopause or a hysterectomy ensues. Because you never know when you could become pregnant. And we certainly want to make sure that we have adequate folic acid in our systems before that pregnancy comes inside. Thankfully, there are some sources, sort of naturally, if you will, of folic acid. The first is obviously vitamins, like we've talked about, so prenatal vitamin. but there are some foods that can have it. So for some folks who really are just averse to taking medications or vitamins or supplements, you can get it in a diet, in a healthy diet. Just got to make sure that you're eating adequate amounts of these foods. So for those who really just don't want to take that prenatal vitamin, things like beans or peas, orange juice, green leafy vegetables, fortified cereals, those can all have folic acid. Since we are, have the luxury of having the audience related to JOWMA, I throw in there just a little bit of questions related to those who keep kosher. And, you do have to obviously be careful with a lot of the issues of bugs coming up. A lot of people shy away from green leafy vegetables, so that's very important. If people have taken those out of their diet, again, you may have a decrease in folic acid from folks who don't choose to eat green leafy vegetables because of sort of the kosher requirements or the washing, et cetera. Folks who are diabetic, or we'll get to it later in this talk, also have gluten allergies. You may find that they are not eating fortified cereals, right? They're trying to reduce their carbohydrate load, or they're trying to make sure they're not having any of those wheat grains. And so again, areas where the government has helped fortify to help decrease risk of neural tube defect and increase folic acid sufficiency, you may individually find yourself as insufficient because you kind of took out the Cheerios from your diet, and therefore that one area of diet that you had is no longer supplying it. So it can become from any of these foods. It's just very important for you to know of your own nutrition and your own body, whether or not you would like to get it in vitamins or in foods, and to make sure the foods you eat have adequate supplies. Iron in pregnancy, we want to see about 30 milligrams of that. And typically we want iron in the form of ferrous sulfate. So if you get that prescription, you'll usually see it like that. The importance about iron is that it's best absorbed with citrus. So basically something that's acidic. If you've ever had iron prescribed to you from your doctor, you've probably heard your doctor say, take it with a glass of orange juice, right? Because that has a little bit of acid and it helps absorb the iron more reliably. This other list of things that I mentioned, things that are non-acidic, so milk and calcium, fiber, those can actually inhibit the absorption. So especially when you're pregnant, and for those who've been pregnant or been with a pregnant woman and have seen them like have so much acid reflux, you know that they're often on antacids. It might be they're taking Tums, it might be they're on prescribed medications or over-the-counter Zantac or something. And so it's very important that the iron be taken not with those antacids because they'll inhibit. So you could be so religiously taking the iron as prescribed, and yet your iron's not coming up and you're getting so frustrated. It may just be a little bit of a modification on the nutrition side that could totally kick that iron back into play. Here are some examples of iron-rich foods. You've got our meats and poultries, eggs, again, the peas and beans, some dried fruit, whole grains, cereals, same sort of caveats that I mentioned before. Just important to know what you eat. You can certainly get iron in foods naturally if you don't choose to take a supplement. And if you do choose to get in your foods, just making sure you're aware of what you're eating based on your different dietary preferences and choices. So in summary, just for folic acid and iron, again, because they're so important, we want 400 micrograms daily of the folic acid. And again, before pregnancy starts. So the moment sexual activity starts, just start taking a prenatal vitamin. Any prenatal vitamin brand is fine as long as it says that famous word prenatal. And we want 30 milligrams of iron that's best absorbed with citrus juices or anything acidic. Just two other kind of quick and important minerals to discuss. We've got calcium. Daily requirement here is 1,000 milligrams per day. And again, we can have sources with vitamin supplementation or a whole host of dietary sources. You can have their dairies, fortified juice, some of the green vegetables, tofu, salmon, lots of different options. So the important question related to nutrition, it'd be very remiss of me if I was talking about all these healthy things, how to supplement, and not talk about the actual weight gain. So how much is appropriate and when should that happen? This is a table that is by the Institute of Medicine. So IOM stands for the Institute of Medicine. And it's for a singleton, meaning one, like as opposed to twins or triplets or something. So when you're pregnant with one baby, the Institute of Medicine, I've highlighted here for a woman of normal weight gain recommendation is roughly 25 to 35 pounds. I find that's slightly helpful to give, but having been pregnant and taking care of hundreds of women, I find that it's really hard for a woman to be able to pace herself, to figure out like, what does 25 to 35 mean over the course of pregnancy? Especially in a woman's first pregnancy, it's really hard to kind of know where things are going to go and how they're going to be. So I find what's easier is to tell her how much weight to gain per week. And basically, I say that in the first trimester, so from 0 to 14 weeks, you should gain nothing. Usually women honestly are kind of nauseated. They may be throwing up. They may just kind of be sort of sick feeling. So they're not usually gaining a ton of weight anyway, but I basically tell them gain nothing in their first trimester. Then from 14 weeks all the way until delivery, which in a regular pregnancy, the due date is at 40 weeks. We can actually deliver sometimes at 39, sometimes a little after. But so from 14 until 40 weeks, you should gain 1 pound per week. And that's going to basically put you in this normal weight gain range. Now, it is important that in the third trimester of pregnancy, that fluid that's, crowding out around your ankles and sort of coming into all other crevices of our bodies that make us just feel very slow, that's going to gain that pound. So it's really not a full pound of, actual weight per se. It's sort of water. So it's just very important to remember, this doesn't mean that you're eating for 2 people and you can suddenly do whatever you want. This is a weight gain of 1 pound per week, starting at 14 or 15 weeks, with the mindset that we're not actually eating for 2, we're eating healthy. And I give some pictorial examples of this. The recommendation is 300 additional calories per day. And that is literally 3/4 of a Starbucks muffin. That's it. That's the extra that a woman should eat per day in terms of extra calories. Now, again, I'm not telling you to eat a 3/4 of a Starbucks muffin every day. That's not what a nutrition talk would be about. But my point is just portion control, that those old adages of you're eating for 2, do whatever you want, aren't exactly where we should be at. We should just be eating healthy with a little extra increment in intake per day. So the fish dilemma is, should we include fish in that diet? On the one hand, it's great for fetal neurodevelopment. It's got omega-3 fatty acids. On the other hand, it's got some mercury, which can be fetal neurotoxic. And so do we use fish? Do we not? What should we do? Big topic that I'm just going to stick into one slide, and I've highlighted the very common kosher fish here. Basically, you should include fish in your diet, but at moderate amounts, the amounts listed above in the table, and you should really keep it to this list over here of the lowest mercury. So things like salmon, filet of sole, tilapia, trout, those are things that you can have basically every week. But other ones that have higher mercury, stay away or just eat them very infrequently. And now just 2 last slides before I hand it over to my esteemed colleagues. The first is because we have our JOWMA audience. Just a reminder, a couple of things for kosher. Prenatal vitamins, there are available with kosher certification. I leave that up to you and your local rabbi to decide if you feel like you need a certification. Many say that you do not, since it is a vitamin pill that's just getting swallowed. But again, I leave that up to you and your local rabbi to discuss, but there are ones that have kosher certification available. The fish oils, DHA supplementation, it's important just to realize from where they come. Fish ones are usually kosher, but ones made from other animals may not be. So again, important to consider the kosher certification issue. And I will not discuss fasting during pregnancy in this talk, but certainly something to discuss with your rabbi and your physician. And my last slides, someone who is vegetarian or vegan, and then sort of another set of gluten. Just important things to think about, making sure you have adequate amounts of all of the various vitamins and minerals, depending, as we talked about before, on what your intake might be. And with that, thank you so much.
All right, thank you so much, Dr. Stoll. Our next speaker is Dr. Denise Moses. Dr. Moses earned her medical degree from SUNY Downstate Medical Center. Dr. Moses then completed her residency in obstetrics and gynecology at North Shore University Hospital and Long Island Jewish Medical Center. She is a board certified OBGYN and works at Healthcare for All Women OBGYN in Fresh Meadows, New York. Dr. Moses.
Hi, thank you so much. Okay, we'll just get started. So I'm going to be talking about prenatal care in a very brief overview. So there's nothing to disclose. And I just want to remind everyone that OBGYNs have two patients. So they have to know which medications are safe in pregnancy. They have to know which tests needs to be done, how to interpret those tests, and which other doctors to consult if needed. So I'm going to talk about pre-pregnancy care, kind of following what Dr. Stoll was saying, intrapartum care, meaning during the pregnancy, and delivery. So many, yes.
Your slides are not showing.
They're not showing at all.
No, I think you need to reshare.
Okay, should I start from here? Are you able to see them now? Okay.
No, we cannot.
Hold on. Sorry, everyone. Now?
Yes, we can.
Okay. It was almost working well, almost working. So, so these were the slides that I had just been discussing. So the fact that we have two patients, etc., and talking about the pre-pregnancy care. So a lot of women come to their OBGYN when they first get pregnant, but we have to plan for prior to pregnancy, just like Dr. Stoll was saying. So we have to plan, we have to optimize our health, meaning, you know, start to become in the best shape, eat healthy, etc., and discuss factors involved like genetics, social factors, environmental, behavioral, and occupational. So in between pregnancies, the best time is 18 months to 5 years. The risk of preterm birth and low birth weight is greatest when the interval is less than 6 months. So people should try to have a space between children. A little bit about immunizations. So we usually give the flu shot and the whooping cough shot, which is the Tdap vaccine, during pregnancy. The flu shot can be given anytime, and the Tdap vaccine is usually given from 28 to 36 weeks, and it protects the baby usually from whooping cough. Adding the COVID vaccine can be given anytime prior, during, or after pregnancy. Measles, mumps, rubella, and varicella are live vaccines, so they're given prior to pregnancy. A lot of women are tested by their doctors if they're immune to measles, mumps, rubella, and varicella, and they're found to be non-immune. If they're not immune, then they get the vaccine postpartum. There's also other vaccines that are available, and those can be discussed with the doctor if they should be given during the pregnancy or afterward. Pre-pregnancy care. So women who have chronic medical conditions also need to discuss with their doctor about different medications that they're taking, how to optimize their health, how to get their conditions under control, and how to make sure that they're healthy for their pregnancy. Many of these women will also see a high risk or an MFM doctor. So women who have high blood pressure and are on certain medications may have to switch their medications diabetes. Women may need to be on insulin. If they have thyroid disease, asthma, or history of bariatric surgery, may talk to their doctor. There are many medications that are safe during pregnancy, but they really have to be reviewed with the doctor prior. So going to your OBGYN before you get pregnant is a great idea because they know which medications are safe in pregnancy, which medications may need to be switched. And some of those medications that need to be switched can cause birth defects. So a little bit about genetic screening. I'm gonna let Dr. Karkowski talk about this more, but many OBGYNs do screen for genetic diseases. And again, a little bit about nutrition and exercise. We have to make sure that people do have a balanced diet. Dr. Stoll just talked about prenatal vitamins, but I want to stress that exercise is safe in pregnancy, recommended at least 30 minutes a day for most days of the week. Don't start a high intensity regimen if you're not used to working out, but it's definitely important to do some sort of exercise during the pregnancy. It's also important to take care of your teeth and see a dentist during the pregnancy as you normally would. So what to expect during the pregnancy, that's antepartum care. So people will have prenatal care visits, sonograms, also known as ultrasounds, different blood tests, and different urine tests. So usually prenatal care visits start in the first trimester. Most babies, we can see a heartbeat around 6 weeks. And a lot of patients are told to come in around 6 to 8 weeks. We have our patients come in about every 4 weeks until 28 weeks, and every 2 weeks until 36, and then every week until the delivery. And we need to see women this often because we want to educate about what testing we're doing, what is to be expected for the next few weeks that they're coming in. We want to evaluate the baby and the mom. We have to figure out any health issues, and we have to have the recommended health screenings and discuss results. So your OBGYN usually takes a full history, and that includes medical history. So any chronic medical problems someone may have, diabetes, asthma, hypertension, or high blood pressure. So those are questions that are usually asked at the first visit. Any prior surgeries, any history of prior pregnancies. People will usually ask if there were any issues or complications in a prior pregnancy. That's important to know for any coming pregnancy. What medications people are taking, and if those are safe in pregnancy. Any allergies that someone may have, that's important to know. Any family history. So in general, doctors always like to know family history of any heart disease, blood pressure, diabetes, etc., and any social history. So social history includes depression, bipolar disorder, and other mental illness, addiction, and intimate partner violence. Unfortunately, intimate partner violence does sometimes get worse during pregnancy. Many people ask, how do we determine a due date? And should we change the due date based on one sonogram or another, or one test or another? So I always tell my patients that ultrasound in the first trimester, which is until about 14 weeks, is the most accurate method. If the pregnancy resulted from IVF or assisted reproductive technology, then they use the age of the embryo and the transfer date. And again, the first date that we get is the most accurate, so we don't usually change the date. Again, this is the guidelines for redating based on ultrasound. So we usually compare the ultrasound measurement of the baby to the the growth of the baby that would be based on the last menstrual period, or LMP. And if it differs by more than 5 days, depending on if the baby's less than 9 weeks, or if it's more than 7 days or more than 10, as you can see in the chart, then we would consider redating or changing the due date. So there are many tests that we do in pregnancy. Many people always ask what's their blood type, or they didn't know their blood type. And most women don't get their blood type checked until they get pregnant. And it's documented for information, and it also goes along with if the blood type is positive or negative. If they're negative, then they might need a medication called RhoGAM to prevent any issues for future pregnancies. We also check for anemia in pregnancy, and that's usually checked multiple times during the pregnancy. If women are anemic in pregnancy, then they may need to supplement with iron. Another busy slide, but common testing that we do for everyone: an Rpr test, rapid plasma reagent. It's a test for something called syphilis, which is a sexually transmitted disease that's known to cause various abnormalities in babies. Sometimes an Rpr test can come back positive. So it can be a false positive, and that's usually then retested with a confirmation type of test. A urine culture is done for asymptomatic bacteriuria. So bacteriuria means bacteria that's seen in the urine. And many women will come back saying, I don't feel like I have a UTI, I don't have burning, I don't have pain when I urinate or anything like that, but they do have bacteria in their urine and they do need to be treated in pregnancy. We also check for protein, and usually protein and glucose at each prenatal visit, depending on which doctor you go to. We also check for hepatitis B, HIV, chlamydia, and gonorrhea, and some women also get checked for tuberculosis. Then, usually getting closer to the end of the second trimester and into the third trimester, we do testing for gestational diabetes. Many women have heard of this. It's that drink that doesn't taste so good. It's pure sugar. The woman will drink it and then she'll have her blood drawn about an hour afterward. If the number is above a certain threshold, then she may need to do a 3-hour test. Also, same very sugary drink. At 36 weeks, we check people for group B strep bacteria. It's a normal bacteria that lives in the vagina. Some women have it, some women don't, and some women have it in one pregnancy and not in the next. We also do genetic testing, as I had discussed, and Dr. Karkowski is going to discuss. We test for neural tube defects, and we test for anatomical abnormalities. So around 20 weeks, an anatomy sonogram, also known as a level 2, will be done to look at all of the baby's anatomy and make sure that everything looks normal. So I thought this was a little funny. I texted my 36-week pregnant wife to ask how she was feeling, and this was the photo I got in response. It's a cat that looks pretty unhappy. So I'm going to move on to delivery. So there's basically 3 ways that people get delivered: induction of labor, labor, and C-section. So induction of labor, women are given medication to stimulate uterine contractions and cause labor, resulting in a vaginal delivery. There's different methods that are used, but usually if women are not very dilated, then they'll need to have cervical ripening, which are different types of medications that cause the cervix to soften and then dilate. And then they're given Pitocin or oxytocin, which is a hormone that women normally make to cause contractions. and it helps to stimulate some uterine contractions. A C-section is an operation. It is definitely not the easy way out. There are many reasons why someone may need a C-section, depending on if they've had a prior C-section, if they have something going on with their placenta, like a placenta previa, if they need one because of the baby's heart rate, or many other issues. And some women who have had a C-section at one point may choose to undergo another C-section or try to have a vaginal delivery. And that's called vaginal birth after C-section. They undergo a trial of labor called trial of labor after C-section, or TOLAC. Sometimes during labor, the pain is so great that a woman can almost imagine what a man feels like when he has a cold. So I'm going to discuss a little bit about pain management during labor. And there's different options. So there's intravenous pain management, an epidural, which is placed by an anesthesiologist, general anesthesia, which the patient will have to go to sleep. That's also done by an anesthesiologist. And there's also other options. It depends really on the hospital that a woman is planning on delivering. And that's it. Please stay tuned for part 2 as soon as we can. Thank you.
All right, thank you so much, Dr. Moses. Our last speaker, last but not least, is Dr. Karkowski. Dr. Karkowski completed medical school at Mount Sinai, her residency at Harvard University Hospitals, followed by a fellowship in maternal fetal medicine or high-risk obstetrics. She now works as a high-risk obstetrics specialist in New York City. Claudia has worked at an ultra-Orthodox hospital in Northern Israel. She now lives in New York City with her wonderful partner, Josh, and their 4 sister crazy kids. She has written for many publications, as well as her own book entitled High Risk: Stories of Pregnancy, Birth, and the Unexpected. She can be reached via her website, www.javikar.com. Dr. Karkowski. You're muted, Dr. Karkowski.
I was asking if anyone can see my slides. Can you see my slides? All right, we are ready to go. We're already doing great. All right, so everybody, my name is Javi Karkowski, and I'm going to do a little bit more of a slightly in-depth review of genetic testing, which I think is one of the most complicated and confusing and maybe anxiety-provoking parts of prenatal care. So I'm hoping this will let you get a little bit of an introduction so that when you hear about these options, they're not the first time that you're hearing them. I have no financial disclosures like Hindi. That's just not a problem for me, for better or for worse. Today, we're going to talk about the difference between screening and diagnostic prenatal genetic testing. We're going to talk about what tests you may be offered in pregnancy and a little bit before pregnancy. And I think this is important, what those tests can and cannot tell you. And I think that all means that you sort of need to think about what you want before you start, because I think so often we don't, and then we end up in a very confusing situation. So sometimes knowing a little bit where these tests can lead can be really helpful in knowing what you want. So just a little bit about me. I'm a high-risk OB doctor. That means I'm an OBGYN who did extra training in high-risk obstetrics. The other name for us is maternal fetal medicine, which means that I take care of women, maternal, with high-risk medical conditions, but also fetal diagnostics. I also perform procedures and high-level ultrasound. I'm also a writer. I write for lots of publications, mostly for lay press, like Slate, The Atlantic, The Washington Post. And as was mentioned, I have a book out, which I don't know if you enjoy this, you may enjoy. It has a lot of information about pregnancy, but also what it's like to be pregnant. A lot of the experiences that I think many of us go through, but really don't see in culture, and so find very surprising, but which I think are some of the most tremendous and amazing stories in the world. So let's talk about what reproductive genetics is like. And I said, what is it like in 2021, actually? Because everything has changed so much, even since I had my first child 12 years ago. So a lot of the genetics we're talking about, people are already offered when they're pregnant, okay? So there are things like carrier screening that I'll get into that you can be offered before you conceive or even before you marry or sometimes even before you date. But a lot of this training you're gonna be offered during prenatal testing is while you're pregnant already. A lot of it is also really concerned with Down syndrome, which I think can be sort of a shock to people because most people don't think that much about Down syndrome in their personal life. And I want to talk a little bit about why. I think all the genetic testing we offer requires sophisticated numeracy. Numeracy is the numerical equivalent of literacy. That means it's really hard to understand things like what your odds are, if your odds are 1 in 500 versus 1 in 600. And as a friend of mine who's very smart and very numerically oriented once said, in the end, it really feels almost like it's 1 in 2 because the answer for any one of us is yes or no. And I thought that was a really good point. I think the options we give you are dizzying in part because the technology is changing every day. And what I want to say about prenatal genetic testing is that the truth of the matter is that everything is probably okay. And what I have trouble with is that sometimes people either don't hear that everything is probably okay, meaning that they are worried all the time, but also people don't hear that everything is probably okay, that we never know 100%, right? Because that's not how parenting works, not in 2021 and not for the thousands of years before. So let me be a little more specific. What I'll say about genetic testing is that basically almost everything we offer you, at least in the year 2021, is a guess, okay? Now, right now, all the things we're about to talk about, all the stuff that Emily and I are going to talk about are guesses. And what I mean by that is that they're screening tests. Most of the tests that look for the number of chromosomes in a pregnancy cannot give you certain information. To get certain information, you need a needle. You need to put a needle in your pregnancy and get some cells. And there are two ways that we generally get cells from a pregnancy. One is an amniocentesis and one is chorionic villus sampling. So this is my very low rent imaging from a blog I wrote a long time ago. This is a pregnant woman lying on a bed with her belly in the air. And this is my terrible picture of a placenta in green, the amniotic fluid in gray, this orange little fetus, and the umbilical cord in blue, okay? Now, when we do an amniocentesis, which is probably still slightly more common, we are aiming for all that gray. We'll usually go through the belly of the pregnant woman into the gray, and you can see there's lots and lots of gray area. When we're doing a CVS, which is usually done earlier in the pregnancy, we are aiming for the placenta, for the green. Does that make sense? In both cases, though, what we are getting is we are getting cells from the actual pregnancy. If you remember, sperm meets egg, makes an embryo. That embryo becomes the placenta, the fetus, and everything else. So the genetics of that will be largely, there's exceptions to everything, in the placenta and in the amniotic fluid. And if we can get that, we can really tell you yes or no. I can look at the chromosomes in that sample because they're actual cells. Because of that, it means that you can pretty much test for lots of things, just a few things, almost anything, if you put a needle in a pregnancy. The cons, the reason it doesn't happen with every pregnancy is because there is a very small risk of any procedure. That risk is probably about 1 in 500 for amniocentesis and probably about 1 in 200 to 500 for CVS. I want to mention this because people get really scared of these procedures, and it sounds so scary. But I'd also like to mention that the rate of loss for pregnancies that we don't touch is much, much higher. It's part of why it's actually hard to figure out what the rate of loss due to CVS or amnio is because people lose pregnancies, unfortunately, at a much higher rate than 1 in 200 or 1 in 500, just in the state of affairs. That's just life. So what I would say is that largely these are pretty safe procedures, but because there is that added risk of loss, many, many other technologies have been developed. And we're going to start to talk about those now. You guys still with me? Okay. So the thing that you need to know is that most of the testing that women are offered or families are offered during pregnancy is really concerned with Down syndrome. Down syndrome is, it's Down syndrome, not Down's syndrome. I apologize for my slide. Down syndrome is trisomy 21, trisomy chromosome, 3 copies of chromosome 21. And here you can see somebody has all their chromosomes laid out from the largest one to the smallest 22 in XY. So this is the chromosomes of a male. And there are 3 tiny little bits of chromosome 21 down here. Do you see that? So this individual has Down syndrome. And the reason that genetics in the modern world is so concerned with Down syndrome is partially because it's really common. I know it's not common in that not everyone you know has it, but when we look worldwide, it's one of the most common genetic problems that there is. It's something that also everyone's at risk. It does increase with age, but anybody can have a baby with trisomy 21. In fact, most babies with trisomy 21 are born to younger women just because more younger women have babies. And I will also say, because of that preconceptual testing, meaning I could test you or your partner for Down syndrome, will always be limited because most of the time it's something that happens just for that embryo as the sperm and the egg met. And so therefore, there's very limited information we can get before that pregnancy forms. And I think the final reason we're so sort of concerned with Down syndrome is that Down syndrome pregnancies tend to look completely normal on ultrasound. About 50% of them will have something that we can see on that level 2 ultrasound that Dr. Moses talked about, but about 50% will not. And for many people, that is very surprising. But that's true. And so it means that that's part of why other tests were developed. I do want to take a moment to mention this advanced maternal age, partially because it's one of my least favorite phrases in the medical language. I do want to mention that Down syndrome, but also all chromosomal abnormalities do rise with maternal age. As we go later and later, we don't really make new eggs. The eggs we made when we were our own fetuses inside our own mother's uteruses. And because of that, those eggs and the chromosomes in them do get a little bit degraded. And so as they kind of get released and meet a sperm, the product is more likely to be abnormal, if that makes sense. Now, it's not like it's ever 100%, right? Everything is probably okay at every age, even here, even at 41, even at 43, even if you get pregnant at 45. But the rate does go up. And the language of advanced maternal age came from a long time ago. It came from the time when your rate of loss from an amnio, way back when people were doing them without ultrasounds or just putting a needle into a belly by palpation, and when it crossed the line for the risk of Down syndrome. And that age at that time was 35. So everybody below 35 was considered below advanced maternal age, and everybody above 35 was considered above advanced maternal age. I do not love this phraseology. I think it's a little misogynistic. Also, I have to say that the risk of amnio has gone down. It's more like 1 in 500. Does that mean advanced maternal age is more like 32, 33? We've never changed that terminology. My point here is that there's no one day where Down syndrome is the thing you need to worry about, right? Every day, we're all a little older. We travel through time 1 minute at a time. And every day we learn more, we're better parents for it. But every day also, the risk of aneuploidy does go up some fractional amount. That's just the truth of humans. Another idea that I want to talk about is this idea of, not everybody wants to put a needle into their pregnancy, and that makes a lot of sense. And so the search for non-invasive methodologies started, and this is 30, 40 years ago, where people were like, could I get the information? Could I know what's going on with my fetus without the risk of loss that is so terrifying to me? And as you can see, we started with chemicals in maternal blood, chemicals that were used for other things. And they started to notice, wow, there's some statistical relationship with some of these chemicals, like an alpha fetoprotein, unconjugated estriol, HCG, et cetera. And they started to figure out what is the relationship between these chemicals and a fetal conditions. And ultimately, I have to tell you, this exploded into a billion different options. You could have a triple screen with 3 chemicals. You could have a quad screen with 4 chemicals. You could have an integrated screen where you had some chemicals in first trimester added to some chemicals that you had drawn in second trimester. And more people started to innovate. And eventually we realized that these blood screens were great, but what would be really helpful? If we could add ultrasound. So we still sometimes use these blood works, these chemicals in your blood, but we've added something called the Nuchal Translucency, which is something that most of you will have when you're 11 to 14 weeks. So the Nuchal Translucency, nuchal is that area right behind your head, which is nice and hard. It's like kind of the end of your skull bone. And it's a thickness. I have a picture right here. This is not the best picture in the world. I think it's one of mine with all patient material removed. And you can see here a fetus relaxing, chilling out. And the back of its neck, you see this space here, right? And that space is what we measure. And you can see down here at the bottom, that space is 1.4 millimeters, which is normal. We measure that space, and that space is wide. It is it is a sign that maybe something is going on. A space that's, generally speaking, some people use gestational age related cutoffs. Some people use 3 millimeters for everybody. tells you that you have a higher risk of having a genetic problem. And it also is helpful for looking things like cardiac problems and other issues. So a wide back of the fetal neck can be a bunch of things, but it's a good clue. That being said, it's not a great clue by itself. We knew that if we just look for a wide nuchal translucency, we only pick up about 70% of Down syndrome pregnancies, and that wasn't good enough. But we know that if we add some of those chemicals, remember those chemicals we were sending, where we send a quad screen and triple screen, if we add a PAP-A and a beta-HCG in first trimester, that we can actually get up to about 85% detection. That means we will detect 85% of pregnancies that have an aneuploidy of Down syndrome. And trisomy 13 and 18, which we'll talk about in a second. So those two chemicals, PAP-A and beta-HCG plus the nuchal translucency, is called the first trimester screen, or the FTS. And for a long time, that's what most people had. It may have looked like this if you got a result. What I think is important here is that what all of these things do is they take your age-related risk, your risk before screening. In this patient, it was 1 in 777 for Down syndrome, and then take it to an after risk, 1 in greater than 10,000. But you can see it's never 0, right? Because to get a 0 in 10,000, we would need a needle. This is a screening test, so it's always only going to give her an odds. And here her odds are very low, but they're not 0. And if she wants 0, she might need to talk about doing a diagnostic test, which involves, generally speaking, a needle. That was the state of affairs, I'm going to say, until about 5 or 10 years ago. And then something was developed, and that test was called Non-Invasive Prenatal Testing, or NIPT. You might also hear it called Non-Invasive Prenatal Screening, or NIPS, NIPS. And as you can see from my slide, there are multiple laboratory companies that are happy to offer this to women, often direct marketing. And I think what's really interesting about NIPS or NIPT is that it's not chemicals in the blood anymore. Now what we're doing is we're taking maternal blood. And as you can see, a fetus is connected to the maternal circulation, right? The fetus is umbilical cord to the placenta. The placenta is attached to the uterus. And in the uterus, that blood, that placental blood, in the uterus, the blood from the uterus goes past the placenta. And as it does, little fragments of DNA from the placenta are shed into maternal circulation. So this is cell-free DNA. It's not DNA in cells. It's just little bits of DNA. I would almost say it's DNA garbage, right? It's garbage that's not in cells anymore. And what we do is we send that maternal blood, we send it to the lab, and through really complex computer mathematical modeling, what they do is they sort of figure out how much of pieces of fetal chromosome 21 are in here. Are there more than we would expect? Are there less than we would expect? So one of the ways I tell my patients is it's sort of looking at the garbage disposal and seeing how much mashed potatoes is there and trying to figure out if you had 2 people or 3 people come over for dinner, right? And that's what NIPT is. As NIPT gets better, it is able to look for little bits and fragments of more and more pieces of chromosome. So for right now, it's looking for chromosome 21, which is Down syndrome. Chromosome 13 and 18, which are more serious aneuploidies, which are both more serious, but also more often picked up by ultrasound. And as it gets better, it may become more reliable for other conditions, which is really wonderful that you could maybe soon be able to pick up actual genetics, DNA from the fetus in maternal circulation without that needle. We're not quite there yet. NIPT is very good in high-risk women. It's probably a little, it may be better in low-risk women. Those studies are still ongoing. It is often very, very expensive. I will say that the thing a lot of my patients really look forward to is that NIPT lets them see the fetal sex. They get to know if they're having a boy or a girl really early. And for a lot of my patients, that's really motivating. What I want to say is also NIPT gets you this really, really precise report, low risk, high risk. And I want to make sure we all know it's really only testing what it tests for. So what NIPT is testing for these days is generally Down syndrome, trisomy 13 and 18. It's not testing for Tay-Sachs. It's not testing for autism. It's not testing for schizophrenia. It's not testing for any number of things that you might worry about because of your family or because of your partner's family. And to test for those, you need to talk to a geneticist, a genetic counselor, and figure out if you need to worry about them. And if so, what's the best way to get that information? Because precision only gets you what you're looking for. Does that make sense? There's also microarray. I just wanted to mention this is a huge development. For this, you need a sample. You need one of those needle samples that I talked about, which you get by CVS or amnio. So this is for cells from an actual pregnancy. But it's really done is expanded our ability to test. So from that, let's say, one syringe full of fluid that I might get from a procedure, we can now test for not just one thing or two things, and not just for how many chromosomes, but we can actually have a slide printed with thousands of different DNA probes and actually look for hundreds or sometimes even thousands of genetic conditions. So this is a really powerful tool. It is also currently pretty expensive. It also can be confusing because if you get a result you weren't expecting or of unclear significance, that can actually be harmful to you and really sometimes provoke a lot of anxiety, which is why if you're going to do tests like this, I highly recommend getting some really good genetic counseling available to you, because I think these tests require a tremendous amount of sophistication to understand and to use properly. I think in the future, we're going to have more precise, non-invasive prenatal screening. I think you're going to be able to get a maternal blood draw at some point and get lots of information about your fetus, maybe even one day look at their whole genome. We're not there yet, but I actually don't think it's that far away. I think that what you're seeing is that in prenatal genetic testing, we are heading towards precision with less risk. And then we have to think about, what do we want to know? Do we want to know just about serious stuff that prevents a child from thriving? Do we want to know about stuff that will affect your child when they're 60? Do we want to know about stuff that only affects your children's children? Or some of that knowledge stuff we'd rather not know? And I think that these are the ethical and really interesting questions that we're going to have to face as our technology meets and exceeds our desire for information. Carrier screening was mentioned both by Emily and I think by Dr. Moses. I just want to mention carrier screening is different. Carrier screening is not just about this fetus. Carrier screening is about diseases that you may carry without knowing because you don't show them. Examples that are really famous are Tay-Sachs or cystic fibrosis. And those you get tested for before you get pregnant and sometimes even before you decide to get married. And that can be really helpful just to know what you're heading into. As I have gone through my pregnancies, I will tell you that the Ashkenazi Jewish panel, based on our ethnicity, my ethnicity at least, was very small when I was first offered it. I think it was 10 diseases. When I had my second pregnancy, it was 18. And by the time I had my last baby, my fourth baby, I think they were like, oh, no, you need to do it again because it's up to 37 diseases. So the technology has expanded. And as it has, we understand more about the communities we need to worry about and the information we can get and how to counsel about those diseases. And that's something it is worthwhile talking with your doctor about before you get pregnant. So finally, these are the things we talked about today. We talked about how all diagnostic testing, if you really want to know, you still need to put a needle in your pregnancy. Most of the testing you'll be offered during your pregnancy is really concerned with Down syndrome and other very serious genetic conditions, but it's not going to tell you about some other subtle things that you might be worried about because of your family history. We spend a lot of time trying to see if we can get some of the information without that needle, without the risk of miscarriage. Even though it's small, we all want risk-free information. We've added ultrasound to give us a nuchal translucency that has really helped sharpen the chemicals that we use in blood. And now we have NIPT and ultimately microarray to give us even more information. And in the case of NIPT, with less risk. We've talked about invasive testing, maternal blood chemicals such as first trimester screen, which we can add to an ultrasound with a nuchal translucency. We've talked about NIPT, microarray, and carrier screening. There's a whole bunch of stuff we talked about, and I bet it was probably a little confusing. But what I'm hoping is that when you do go to your doctor, it's not the first time you've heard these terms, and that when you approach them not just with an idea of what a lot of people do, which is to say yes to everything, that you really understand what you're being offered and you know how to use it in a way that works for your values and your life. All of these tests are optional. Nobody has to get any of them. And if you do get them, I hope it's because they're useful. None of them really should be used just to create anxiety, but neither should they be used just to tell you that everything is okay, because everything is probably okay as it was before you got the test and as it will likely be after you got the test as well. If you ever want to contact me, my website is javicar.com. And if you enjoy this kind of work, you might enjoy my book as well. Thank you so much.
All right, well, thank you so much to all of our speakers. We're about to start our Q&A. Feel free to continue asking questions in the chat. And please keep in mind that we can't give specific medical advice. Right, so a couple of questions that were asked in the chat are about VBAC, or vaginal birth after C-section. So can you please speak about women's eligibility for VBAC and what the success rates are for this? Anyone feel free to take it.
All right, I'll start off, and if anyone has anything to add, they can. So the VBAC, or vaginal birth after cesarean, it's usually what happens after the woman gives birth. We usually try to see if a woman is eligible for what we call a trial of labor, or TOLAC. And what we look at are a couple of different factors. One of them is, why did she have a C-section the first time? Is she willing to go through with a trial of labor this time, or does she want another C-section? That's totally up to her. Does she understand the risks? One of it is uterine rupture, which is a less than 1% risk, but can be extremely devastating if it does happen. And is she eligible for a vaginal delivery this time? So she doesn't have a placenta previa. She didn't have a classical C-section, which is an up and down scar on the uterus. She doesn't have any other reason why she would need a C-section or could not deliver vaginally this time. And would the hospital that she's delivering at be able to accommodate someone who is trying for a vaginal delivery after C-section, and God forbid if they need a C-section while they were in labor?
I'll just piggyback onto what Dr. Moses mentioned, and I totally agree with everything she said. Just wanted to highlight that last point, putting a little bit on my JD hat for a quick moment, is that is important for all the women out there contemplating their options, and that not all hospitals and not all providers will offer a TOLAC, or a trial of labor after C-section, even if you may be medically available to pursue one. So it's very important as an advocate for yourself, or for your partner, or for your sister, or your mother, or your daughter, whomever the pregnant woman may be. If this is something that she wants, it's very important to be an advocate and to ask about that in advance, and then make the appropriate arrangements so that you can deliver at a hospital that does offer this, with a provider that does offer it.
And can I just mention one last thing? Oh, I don't know. Are you guys able to hear me?
Yes.
I've lost faith in my technical abilities. The one last thing is that I think for somebody who's had a C-section, especially an unplanned C-section, that can be really hard. And I think that having that second baby can really, some people really want to feel control. They choose a second C-section, and some people really want to exit the C-section sort of path and get on the vaginal delivery path, which I think is really important if you're considering having a large family. It's rare to have complications from C-sections, but they do get riskier and riskier as you have more and more. If you're thinking of having 6, 7, or 8 kids, I do think a TOLAC has a different decision tree than if you're somebody who knows you're done after 3 or even 4. And finally, I want to mention that the risk of uterine rupture, what Dr. Moses mentioned, which is so scary, although rare, is lower if you have at least 18 months between your delivery and your next pregnancy. So just for women who are thinking about that, really letting your uterus heal before it starts growing another pregnancy can be at least one thing you can think about doing to maximize your chance of being allowed to labor, of finding a provider that would support you, and feeling like you've really done your best to give yourself your best option.
Great, thank you so much. Our second question is, what do you say to women who are concerned about getting pregnant that are over the age of 35?
Well, I think I've been clear that I think you're still young and beautiful. I hate this language. I think, first of all, I think we just need to be a little kinder to ourselves in general, right? A lot of my patients say, oh, should I have gotten pregnant 10 years ago? I don't know. Should you have? Maybe you didn't have the partner you needed. Maybe you didn't have the financial security you needed. To divorce these things is to really ignore the way that humans develop. We need our bodies, our minds, our hearts to all be ready. So first, I just want us to be kinder to ourselves, because I think women feel so much pressure to optimize their pregnancy. And I'm going to tell you that everything is generally okay. Age 35, age 40, age 42. That being said, it is always helpful sometimes to have somebody like Dr. Stoll or myself involved, who can really work with some aspects and sort of work with your generalist doctor and see, you know, are you high risk? If you have any medical conditions, can we optimize them so that when you get pregnant, you're in the absolute best place you can be? I'm sorry for the fireworks. New York City is partying.
All right, it's no problem at all. It sounds fun. All right, next question. Should everyone have an NIPT or just some women with some risk factors? And this is open to anyone.
I'm happy to jump in here. So non-invasive screening is a great tool for most people. So as Dr. Karkowski mentioned, you know, basically what it tells you is there a high risk or is there a low risk? And for some people, they really want this information. You know, it's a good alternative to doing a CVS or amniocentesis for people who really are not wanting to proceed with those procedures, at least to start. So it's a way of getting some information about the health of your pregnancy while not putting the pregnancy at any additional risk. That being said, once you learn the information about a genetic test, you can't unknow it. So for somebody who undergoes this test and they find out that there is a high risk for something, it really can cause a lot of extra stress for the remainder of the pregnancy. So a lot of people will use that information to make a decision about CVS or amniocentesis. Other people, you know, will not do a test with a needle under any circumstances, in which case, you know, they should think about ahead of time if they're, you know, if that information is going to be helpful or harmful to them in the pregnancy. Another thing which was mentioned before is that it's expensive, depending on your insurance and your age and what else is going on in the pregnancy. It may or may not be covered by the insurance. So unfortunately, that's something that we also have to take into account when we're making decisions about a genetic test.
I just wanted to add the whole thing there. I think somebody also questioned, like, why would I get that test if I wouldn't consider termination? And you know, that's one way of thinking about it. And for many women, that's sort of the end. If I wouldn't do anything differently, you know, why should I get a test? And Emily's point is right. Sometimes then we just achieve anxiety. I will say also, and I learned this really well when I worked at ultra Orthodox hospital in Netanya, which is that I think there's also room for knowing information to prepare. So for example, if you're anticipating a pregnancy with a baby that has some really high risk medical conditions, you might not want to deliver at a smaller hospital. You might want to create a team. You know, I know that, for example, at my hospital, if we know we're anticipating a baby with a cardiac defect, what an opportunity for us to allow you to meet a cardiac surgeon and get that team together before you deliver. So I do want to say that I think the relationship with information can be more nuanced. It doesn't have to be, if I don't want a termination, I don't want information. I think information can be used in lots of different ways. Preparing yourself, preparing to make sure that you have the best outcomes, even for a really difficult pregnancy. And I think that that's fair, right? That can be therapeutic as well. So I think our relationship to decision-making is maybe more complicated, but also more nuanced. And there's a little more room for that, I'm hoping, in today's counseling.
Yeah, absolutely. And I totally agree with that. And I think that's why it's such an individualized discussion with, you know, the person and their doctor and their genetic counselor, because there's not a one size fits all that, you know, NIPS is the best test for everybody or it's not. I think there's so much information that's useful. There's also a lot of information that's a little bit of overload. But, you know, she's totally right in that, you know, let's say we know a fetus is at risk for Down syndrome. We'd recommend an extra ultrasound during the pregnancy to check the baby's heart, because a lot of babies have heart defects. And, you know, this can be useful going into managing the pregnancy, you know, and a plan for delivery. So there's a lot to knowing the information, even though, you know, you can't change the genetics of a pregnancy. You can really change a lot of things surrounding it.
And just to follow up on this discussion, do you find that genetic testing can help someone who has had prior miscarriages, giving them more information, things like that?
Yeah, for sure. So, you know, one thing is by knowing the genetics of a pregnancy that was lost, that can actually give us clues about why that happened and potentially is it likely to happen again. If we don't know the cause, So somebody in my office who's had 2 or more miscarriages, we'd actually offer to look at the parents' chromosomes, because sometimes parents have a rearrangement where it doesn't affect their health, but there might be, for example, one of the parents has 2 pieces of chromosomes that have swapped places, or 2 chromosomes that are stuck together, which when they go to make egg and sperm, it can actually result in an unbalanced version of what the parents have. So it can cause a higher risk for miscarriages in the future. So that's sort of one example. But definitely, for any couple that's had recurrent miscarriages or stillbirths, certainly seeking out more genetic testing may be able to give them that answer. Although frustratingly, in a lot of cases, it doesn't. And ultimately, for most couples, we actually don't know the reason, which can be really frustrating. Even though obviously normal genetic testing is good news, it does leave a little bit of a question mark.
All right. Well, thank you all so much. Just one last question before we go, and it's more of a technical one, but can you please explain what a neural tube defect is?
Sure, I'll take that one. So a neural tube defect it's a sort of global or broad term for a defect or problem or sort of injury in the neural tube, which is basically the embryologic precursor to the neurologic system. So if you have a neural tube defect, that might mean something that is a problem in the brain or spinal cord. So the specific examples that I had noted in folic acid deficiency are spina bifida, which is where there's a problem in the spine, usually towards the sacrum or kind of towards the buttocks area. And then there can be an outpouching of the spinal sac and sometimes the spinal cord as well. Or encephalocele, which is sort of a defect usually at the base of the skull, kind of in an area, it's usually called the occipital area, but kind of at the very high part of the neck, right where the neck and the skull meet. And you can have a little outpouching where you can have some brain coming out. So it's basically an overarching term for a problem with the nervous system, specifically the spine or the brain.
All right, thank you so much for that. So thank you everyone for joining us at JOWMA's OB Basics webinar. Thank you to Dr. Moses, Dr. Stoll, Dr. Karkowski, and Emily Goldberg from JScreen. And thank you to JScreen for sponsoring. Thank you to the Women's Health Committee, Sahar, Denise, Miriam, Dr. Spiegel-Strauss, Jackie, Tamar, Shandy, Nuchal, all for organizing. And thank you for everyone that asked questions and attended the webinar. We hope to see you at future webinars, including Obstetrics Part 2. And we hope to see you then. Have a good night, everyone.
Thank you so much.